Good afternoon, everyone. We're just giving it a minute or so while people join. It's great to have you all with us today for this Cracks in the Ice webinar. So thank you for those of you who are joining us today. Welcome to the Cracks in the Ice webinar, which is titled Methamphetamine Overdose, Trends and Harm Reduction. For those of you who are joining for the first time, my name is Steph Kershaw. I am a research fellow at the Matilda Centre for Research in Mental Health and Substance Use, located at the University of Sydney, and project coordinator for Cracks in the Ice Online. And it's my great pleasure to welcome you today. Before we begin, I would just like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people of the Eora Nation, and I pay respects to elders past and present. Before we begin today's webinar, there's just a couple of things to let you know. Firstly, you are in participant only mode, and that means that we can't see or hear you. However, if you look on your dashboard, you will see that you've got a Q&A button there, and that's where you can type in any questions that you have during the webinar and send them through to us. And we will also have a dedicated question and answer session at the end of the webinar with our two presenters today. Also, if you haven't already seen the website, I would encourage you to visit cracksintheice.org.au, and we welcome any comments or questions that you have, so feel free to get in touch with us at any time. So today, we're very excited to welcome two presenters, Associate Professor Amy Peacock and Emeritus Professor Shane Darke. So Amy Peacock is a Deputy Director of the National Drug and Alcohol Research Centre, and she is the project lead for Drug Trends, Australia's national illicit drug monitoring system. And Emeritus Professor Shane Darke has worked in the field of illicit drug research at the National Drug and Alcohol Research Centre since 1988, which I won't tell him is actually the year that I was born. And he is also a leading world expert on morbidity and mortality associated with illicit drug use. So thank you so much for joining us today, Amy and Shane. We're really delighted to have you with us, and I'll hand over to you to make the presentation. Thank you.
Thank you so much, Steph. Thank you for the invitation to talk today, and thank you everyone for joining us. I hope that we can give you some interesting and useful information and a great discussion at the end. So as mentioned, we are from the National Drug and Alcohol Research Centre, and in particular my role relates to Drug Trends, which is a national drug monitoring system where we bring together different data sources to understand what's happening with drug use, markets and harms, and we're funded by the Commonwealth Government. To start off with, I too would like to acknowledge the traditional custodians of the lands on which we meet today. In my case, it's the Mawinea people here in Nipaluna in Hobart, but I'd also like to acknowledge the custodians of the lands on which we all come from today and which we conduct our work, and any First Nations people joining us today. As mentioned, the work that we're going to be presenting on today has been funded by the Australian Government, so to acknowledge their contribution to drug monitoring and surveillance in Australia, the broader team who support the work that we're presenting here, and I'd also like to acknowledge those with lived and living experience of substance use who've contributed to the work that we're presenting today. And just a little bit of additional admin, but obviously today we're going to be talking about methamphetamine overdose or toxicity and broader harms related to methamphetamine, and that can be a topic that can raise questions or sometimes cause distress for people. So if you do need are interested in further resources, there's a number of helplines and information sources here. In particular, the National Alcohol and Drug Hotline, which is a 24-hour confidential helpline service. But to start off with, let's situate ourselves in terms of what are we talking about when we're thinking about methamphetamine in Australia. So methamphetamine, it's a potent synthetic drug that is manufactured in laboratories from a range of precursors. Sorry, let me just bring my slides back. 2 seconds. What just happened there? There we go. Sorry about that. It's actually part of a broader family of amphetamine type stimulants. Things like MDMA and pharmaceutical stimulants are classified within this broader class. And essentially what methamphetamine does is it speeds up messages between the brain and body, and it can make people feel more awake, energetic, confident, more able to socialize, reduce inhibition. But it does fall under international drug control and is an illegal drug in Australia. And I'll let Shane talk a little bit more about methamphetamine and how it may have negative effects on the body. But just to start off with, I do want to talk about the main forms of methamphetamine that we see in Australia. These three forms reflect different stages of the chemical synthesis of the drug. So that first image we're seeing is what we call crystal methamphetamine or ice. It's very chunky, rock-like, and it is typically the highest purity form. Because it's in that rock form, it's less likely to be adulterated. With that, we see that people often smoke or inject this form, and the risks associated with crystal methamphetamine can be higher because of that higher purity, and we see people more likely to develop dependence on that form. The other form that we hear less about these days is the base or free base form. This is less common these days in the Australian market, and it looks quite oily and waxy. And then the final form that we have is the powder methamphetamine or speed. In the early 1990s, when people talked about speed, they were typically talking about amphetamine, but what we see in the market these days is this powder or speed form is very much methamphetamine, typically coming in a white or yellow type color, and it's typically of lower purity relative to the crystal form. So it's more often cut with adulterants. And we see people kind of typically snorting, swallowing, or sometimes injecting that form as well. Now that we've given you a bit of a grounding as to what we were talking about when we're thinking about methamphetamine, I'm going to hand over to Shane to talk a bit more about what methamphetamine toxicity looks like.
Thanks, Amy. Well, I think the important thing here is we're using the word toxicity. Overdose is not really the term here. There is no strong dose response with methamphetamine and the other psychostimulants, and low concentrations can actually cause toxicity, cause overdose, or if we use that term, but death in extreme cases. Now, when we look at a drug like opioids or alcohol, we're looking at a syndrome that's all about respiratory depression. With methamphetamine and drugs such as cocaine, we're looking at cardiovascular effects and neurological effects. It's a very different syndrome. And I would say this about methamphetamine, as someone who's studied it for many years now. In my opinion, it's the most toxic drug that I've studied. It's toxic to just about every organ system. And I mean, the big change that happened in my lifetime or my working lifetime, was, as Amy said, in the 80s and 90s, it was powder about 7% pure. 2001 onwards, suddenly we got 50% forms of the drug, which means we've got very high levels of dependence. All right, well, let's have a look at what acute methamphetamine toxicity looks like. As I said, we're looking primarily at cardiovascular effects. Amphetamine places stress upon the cardiovascular system. Now, when we look at toxicity in the cases where I've studied deaths, for example, or near deaths, the sort of cardinal signs and symptoms are arrhythmia, an irregular heartbeat. Methamphetamine's arrhythmogenic, and of course, an irregular heartbeat can result in a cardiac infarct. It puts pressure on the heart with you get a tachycardia, that's an accelerated heartbeat. People may think, oh, that's just normal, but highly accelerated heartbeats can cause arrhythmias and cause an infarct. It's not just normal, it's sign of a cardiovascular system under stress. And one of the major things that we see is hypertension. That's high blood pressure. You get these hypertensive spikes, again, placing pressure on the heart and the entire cardiovascular system. One other thing that we see is hypothermia. Now, we're talking about people having degrees of like temperatures of say, 42 degrees Celsius. In the death study I did a few years ago, well, 1/4 of cases, the person was recorded as being hot, unable to be cooled down prior to death. Now, hypothermia has a whole lot of effects, knock-on effects. It can cause rhabdomyolysis, that is muscle cell destruction. Now, that happens with drugs such as the opioids, but that's because people fall unconscious and lay down on say, a leg for hours, and it causes crush syndrome. In this, the hypothermia actually is destroying the muscle tissue. And this can have knock-on effects, again, apart from the fact that there may be irreversible damage, acute kidney injury, liver failure from hypothermia. But also I should point out that methamphetamine is actually hepatotoxic, actually directly damages the liver. Now, one of the most common symptoms that were reported is chest pain. In fact, amongst young people presenting to A&E, chest pain's the main. If someone's a young person's coming to A&E with chest pain, be suspicious or investigate whether stimulants are involved, because clearly what that's saying is the heart. You may be in the early stages of a heart attack. Now, another way to look at the neurological side of it, all the stimulants may cause seizures, fitting. This comes for two reasons. One can come from the hypothermia, febrile fitting, but it's also the drug itself affects the affects the neurotransmitters and can directly engender seizure. Now, quite often with that heart attack, the heart thing, when we looked at the deaths, and something like 1/3 of them reported laboured breathing, like that people around them said that the person was struggling to breathe, which is not like overdose with a drug like heroin, where basically people just, their breathing goes down to like 4 breaths a minute, etc., even amongst tolerant users. And gradually there's a cascade into coma. This is a sign of cardiovascular distress, and it's serious, and you need to get it to an ambulance. And the most common thing that we found with like 60% of people who died of methamphetamine toxicity just suddenly collapsed. They just literally collapsed with an acute cardiac event. The other one I want to mention, it comes back to that hypertension, is hemorrhagic stroke. Methamphetamine has a 5-time increased risk of hemorrhagic stroke, that is, bleeds in the brain. We know that from our work that amongst young people who have strokes, and some of you will be pleased to know young's defined under the age of 45, 1 in 5 of that, 20% involve a stimulant, mostly methamphetamine having occurred. The other thing is they occur deep in the brain. With general strokes amongst young people, 3% die. Methamphetamine strokes, 30% die. They're deeper in the brain, and the weaknesses in the walls of the arteries in the brain, aneurysms. You may live to be 90 with that, and then find out, and then die of something else. You put a drug in that's causing spikes in blood pressure, it may burst. Just briefly, then there's also what's different at behavioural. As I say, drugs like heroin, people go to sleep. These drugs activate people, and in extreme cases, there's delirium and agitated delirium syndrome, where the person may just literally be running around delirious and causing themselves damage, or literally drop down from a heart attack. You get paranoia, acute paranoia, and manic behaviour. These drugs activate. These are a different aspect of overdose that will make people at higher risk of trauma, and maybe risk to trauma to other people. Now, I'd like to just finish by looking at the chronic effects of the drug, because these are important. Regular use of methamphetamine can cause a number of damage to the heart, and it doesn't matter what your route of administration is, it's causing damage to the heart. I mean, that's interesting. So it's a direct effect of the drug. And the sorts of things I'm talking about all affect the ability of the heart to pump. It causes cardiomegaly, enlargement of the heart, what's left ventricular hypertrophy, that is the pumping chamber of the left is thickened, reducing pumping efficiency, accelerated coronary artery disease, clogging of arteries, hardening of arteries. So the whole system's got to work harder to get blood into the heart, and you're putting a drug in that increases myocardial oxygen demand. A dilated cardiomyopathy, all of the heart chambers dilate, again, reducing efficiency. Sorry, my clock's telling me something. That can occur quite rapidly. In people who are susceptible, you can develop cardiomyopathy within under 2 years amongst young people. So all of this is a picture of hypertensive and ischemic heart disease. Accelerated heart disease I've used the term before, and it actually is pretty much true when you look at 70-year-old hearts in 30-year-old bodies. Why does this matter? Well, obviously, in and of itself, it matters. So you've got a drug that's putting strain on the heart, and you're damaging the heart as you do, and then you take more of the drug with a damaged heart. So unlike a drug like heroin, where each use event is sort of an independent risk, the use of the drug, the regular use of, in particular, of methamphetamine, has a cumulative risk in the sense that you actually cumulatively damage the cardiovascular system. And then it's at reduced ability to deal with the effects that the drug puts on that system. And you can see that, amongst older people in particular, and believe me, people use methamphetamine in the 50s, 60s, and particularly older men. You've got people who are already at higher risk of cardiovascular disease. Right, well, I think that's the main difference that you need to keep in mind about the toxicity, the cumulative interaction of the damage caused by the drug and the acute effects. And just before I hand over to Amy, there's a couple more. I just wanted to mention, if you're interested, some of the resources that we've got on that. A couple of years ago, put out goodness me, everything seems longer. Last year, we put out a book, The Pocket Guide to Drugs and Health, revised edition. It's literally is a pocket guide, reference-free, page at a time. I spoke on the psychostimulants in an NDARC Drugs in the Body series, that covers this and all the other organ systems. Then, of course, there's always the NDARC fact sheet on methamphetamine. But that's enough from me, I'm sure. And Amy, we'll pass back to you.
Thanks, Shane. And I might pick up on some of the messages that you just shared there around what to do in the event of methamphetamine toxicity. I think one of the key things that you were really emphasizing, Shane, there is both the impact of the acute and the chronic cardiovascular effects. And I think if we're thinking about really practical strategies, one of the key things is if someone's talking about having a racing heart or chest pain, this is potentially a sign that immediate help is needing. People may think it's part of the come down experience, but it can indicate a more serious heart condition. So this is a sign that help may be needed. And then a lot of the other things are potentially myths around things that we think may reduce the risk of toxicity, but potentially may actually increase risk. So things like people may take depressants like alcohol or benzodiazepines, thinking it'll help to come down from the stimulant effects, but actually it can potentially even mask the effects, place additional strain on the body, and increase the risk of both overdose and mental health effects. Similarly, you may hear people talking about, putting people in the shower or the bath to help them cool down or sober up. Again, that can elevate risks of things like fainting, seizure, falling in the shower. Rapid temperature changes can also place the body under stress, and it can make it difficult to monitor how the person is going as well. And similar, this idea of kind of leaving people to sleep or to rest. There's a risk there that they can fall into unconsciousness or that symptoms can worsen, and that can be quite problematic. So in terms of things to do, as Shane mentioned, the number one thing that you can do is to call an ambulance. Where possible, try and explain what the person has taken, what the circumstances are, and to give them that information. Also essential is to stay with the person. If possible, try and have them in a safer, in a quieter environment. If they're unconscious, thinking about putting them in the recovery position, monitoring their breathing, and if need be, starting CPR. That whole point around maybe avoiding putting them in the shower or the bath, that holds true, but if they are overheated, thinking about ways that you can cool them down. It might be loosening tight clothes, putting damp cloths on them, giving them sips of water, continuing to check that they're alert. And the other thing as well is if you do suspect that opioids might be involved, thinking about giving naloxone to people. It won't reverse the effects of the stimulant, but it will reverse the effects of the opioid. So naloxone is something that anyone in Australia can access over the counter at a pharmacy. But in an ideal situation, you're trying to avoid the overdose actually, or the toxicity actually occurring. And there's a number of strategies that harm reduction strategies people can look to implement to try and reduce that risk. Key amongst those is really trying to avoid binging over several hours or days. Overdose risk rises with that cumulative use. And then just around healthy habits as well, planning ahead around how to stay hydrated, but not consuming too much water, thinking about avoiding drinks like alcohol, caffeine, etc., that will also contribute to becoming dehydrated, taking breaks if dancing or similar to avoid overheating, thinking about eating before a session, having food ready to eat later on, and sleep being really critical, particularly from the mental health side of things. So trying to get some sleep, or even just trying to rest in a quieter environment, just the rest alone can help. We talked a little bit about trying to avoid taking depressants with methamphetamine because of the risk there, but really more broadly there's a risk around polydrug use, around using other drugs with methamphetamine, and that may include medications that people are on. So the safest thing is ideally not to be using anything else with methamphetamine. Key amongst it too is really thinking about the backup plan. Who knows? Who's safe in terms of knowing what's happening for you, that you're using, and won't judge and can kind of keep an eye on what's happening for you, and if you're starting to experience difficulties. And then the motto, start low, go slow, really does apply. Every batch can be different, so trying a little bit first to test it out, asking others about their experience from that batch. If it's accessible in your state or territory and it's nearby, trying to get access to drug checking services. And as I mentioned, we are hearing reports around methamphetamine adulterated with opioids, particularly quite strong opioids. So thinking about carrying naloxone is a wise action as well at the moment. So if that's how we can try and avoid the risk of methamphetamine toxicity, what are we seeing more broadly at the population in terms of trends in harms? Before we get into the trends, I just want to talk a bit more about the risks associated with regular or problematic methamphetamine use so that we can start to disentangle what's happening over time. But studies have shown, we've undertaken reviews of the literature, and what we've been able to show is that people who engage in regular or problematic methamphetamine use relative to the general population, they are at increased risk of things like substance dependence and toxicity, like we've talked about, but there's increased risk of a range of other health outcomes, things like mental health conditions, so depression, psychosis, and violence. We see increased risk of some infectious diseases like HIV and hepatitis C. As Shane's talked about a bit, we also see risks around cardiovascular, respiratory, and neurological conditions, skin and soft tissue infection, and other injuries, things like motor vehicle accidents and falls and whatnot. Some of these risks are elevated more around the ways in which methamphetamine are used. So, for example, people using the drug by injecting or associated risk behaviour, so things like sexual risk behaviours. But overall, these are what we see being elevated among this population. And unfortunately, what it does translate to is an elevated mortality risk overall relative to the general population. So when we compare the mortality rate for people who engage in regular or problematic methamphetamine use relative to their peers in the population of same age and sex, we see that their risk of mortality is about 6.8% higher. And this is really driven in part by drug toxicity and mortality, but by other causes as well. Things like accidental injury, suicide, cardiovascular disease, and homicide. So now that we have got a bit of a picture of what the harms are from methamphetamine, it's probably timely that we look to see what is happening over time in Australia. And what we're seeing when we look across a range of data sets is that methamphetamine harms really kind of increased from around 2010 and increased up until about 2019, 2020. We saw some indication that there's been a stabilisation at this high level since then. So to start off, looking at hospitalisations, we've studied methamphetamine-induced hospitalisations across Australia, and what we've seen is a really quite a stark increase in methamphetamine-induced hospitalisations, and in fact, methamphetamine being the main drug that we see identified. Similarly, in deaths, overdose deaths involving, or poisoning deaths involving amphetamine stimulants, we've seen quite a big increase, and the majority of that we do attribute to methamphetamine from what the coroner reports indicate. And also looking at national alcohol and drug treatment episodes. Again, we've seen a really big increase, particularly up until around 2020, in the number of people who have sought drug and alcohol treatment for methamphetamine as their principal drug of concern. And these harms, sorry, I'll just sneak back, these harms are concentrated among some particular demographics. So when we look, this is focusing specifically on hospitalisations and deaths at this point. When we look across those two data sources, what we consistently see is that males are overrepresented in these data sets in terms of experience of harm. Males have always had the majority of harms that we've observed in these data sets, but the gap has actually widened between males and females as the rate has increased. We're also seeing quite an interesting picture in terms of age. So looking back 10, 20 years ago, really the age that had the highest rate of harms was those who were aged in their 20s. As the years have gone by, in more recent years, what we see is a shift in that age profile, and it's really more concentrated among those in their 30s or 40s. But those between, say, the 20s to the 50s are really kind of the primary age group at the moment. Looking across the country, there has been some fluctuations in terms of the rates of harms. We do see South Australia experiencing quite high rates of harm, and there is a strong market in South Australia. Things have fluctuated a bit in Northern Territory. Rates have been higher there, but I think it's important to say that methamphetamine is not an issue for any one state and territory. We see high rates of harms across the board, really. In terms of the factors that are or the diagnoses underlying these harms, really poisoning is one of the key, or toxicity, as we've talked about, is one of the key drivers, but also what we would call mental and behavioural disorders due to substance use, so things like dependence and withdrawal. And notably, we've really seen an increase in the rate of harms in remote and very remote areas for methamphetamine. These harms are particularly elevated in certain population groups as well. I just want to focus on Aboriginal and Torres Strait Islander people here. So data from the Australian Institute of Health and Welfare is showing that people who identify as Aboriginal and Torres Strait Islander are twice more likely to use methamphetamine than those who do not identify as Aboriginal and Torres Strait Islander. But what we see is that the risk of harm is even more elevated and disproportionate relative to that excess use. So looking across, we've got a bit of a picture across different states and territories, and really what we see is that Aboriginal and Torres Strait Islander people are up to 9 times more likely to have a methamphetamine-related hospitalisation. That's some data out of New South Wales. And what we see as well is that that trend is increasing over time. So we're really seeing an elevation in harm for this population. So, I mean, research that has focused on Aboriginal and Torres Strait Islander people who have recently used methamphetamine show that they report significantly higher rates of racial discrimination, excessive grief, social isolation, and complex trauma. And if we think about not just this increased use of methamphetamine, but all of the impacts around colonisation, disadvantage, stigma, the barriers to care, and really, I guess, the need around culturally appropriate treatment option, there's a lot that we can do in this space to try and improve outcomes, I think. So why might harms be increasing related to methamphetamine? There's a lot of possible reasons. I'm going to touch on 3 of them now. The first of them that I'd really like to highlight is this increase in supply that we're seeing, not just in Australia, but globally. So methamphetamine, it's a relatively easy drug to make. It can be efficiently synthesized from pharmaceutical precursors and with pretty readily available chemical reagents. This ease of manufacture has meant that we've really seen growing production in lower income countries, particularly those that have weak regulation on precursor chemicals. And it means that this market is quite profitable. And Australia, unfortunately, has one of the most profitable markets globally, which has incentivized international and domestic organizations who are looking to supply illegally to Australia. With all of the technological and other advances that we're seeing as well, it means that manufacturing is becoming more sophisticated. And what we're seeing globally is much larger shipments occurring on a much more frequent basis, which presents some big challenges for law enforcement. And indeed, we conduct interviews with people who use illicit drugs and specifically methamphetamine across Australia each year. And consistently in the last 10 or so years, what we hear people telling us is that they find crystal methamphetamine in particular to be easy or very easy to obtain. The second potential factor I want to touch on is the fact that drug markets are quite resilient to disruption, and there is ongoing demand for methamphetamine in Australia. So despite a small dip in availability and in turn in consumption around the COVID-19 pandemic, we did see people report availability of methamphetamine was more difficult and a somewhat of a decline in use. We have seen that markets have partially recovered since then, and there is that continued demand. So what you can see on the slide here is data from our National Wastewater Drug Monitoring Program, where they monitor drugs from wastewater samples. And that has shown that we've seen this kind of general increase over time. Now, the challenge with wastewater data is it can be difficult for us to disentangle what's going on here in terms of the rise of consumption. And it's likely, again, a few things are going on. Likely that there are increases in terms of the number of people who are using methamphetamine, but we also know there's been some really big shifts in the market. So while we know that the price has been relatively consistent for methamphetamine, we've seen that the purity has increased. And so it might be that people are, that there's been an increase in the number of people using, but also that those who are using more frequently or are using more pure forms. And that is contributing to this rise in consumption as well. And as I've just mentioned, I think a third factor that we really can't overlook is just this shift to a higher purity form and riskier patterns of use that may be contributing to the elevated harms that we're seeing. This first figure that you can see, this is from our surveys with people who regularly inject drugs across all capital cities in Australia each year. And historically, where we would have seen heroin was the main injected drug, by far and away now, methamphetamine is the main drug used. And for the most part, as you can see, so in the 24 data, 4 in 5 of them were saying that they were using crystal methamphetamine. The use of powder has really declined of late. We're also seeing shifts in the patterns of use. We're seeing more people smoking the drug. This is data from our sample of people who inject drugs, but similarly from the data that we've got where we speak to people who use drugs like ecstasy, we're seeing more use of the crystal form and more smoking of the form. And concerningly, as I mentioned before, has that frequency of use increased? Well, yes, it definitely has from the work that we've done. Among people who inject drugs who use methamphetamine, we've seen a really big increase in the frequency of use. So we're now at the point where people are talking about using crystal methamphetamine approximately 3 times a week. And with our samples of people who use illicit stimulants in a kind of more drugs like ecstasy and cocaine, the people in that sample who talk about using methamphetamine, they're often using kind of twice a month, where 10 years ago they would have been talking about using once or twice in the last 6 months. So if we are seeing this picture where harms have been rising and are staying at this really high level, at this higher level, what can we do to try and reduce this risk of harm? So this is work that has been undertaken by Rebecca McKetton at the National Drug and Alcohol Research Centre. Rebecca's undertaken a number of reviews and work over the years looking at evaluating the impact of different treatments and interventions around stimulant use. So this was a recent piece of work that was done. And what Rebecca and the team found was that there is some evidence around the impact of psychosocial interventions, and particularly contingency management really seems to be standing out as a strong treatment option. This is where people are provided with non-financial or financial incentives in exchange for evidence of abstinence from their stimulant use. This can be coupled with things like cognitive behavioural therapy or used on its own. It's, yes, less widely adopted in Australia. There are some challenges around its adoption, but there's a lot of work going on to see how we might be able to scale up its use. One of the big challenges, though, is that unlike other drugs like opioids or alcohol, where there may be medications that could be used in Australia, we just don't have an approved medication that for methamphetamine in terms of a drug that would help to reduce cravings or relapse from methamphetamine. There are a lot of trials going on testing different medicines that may be able to work, but at this stage the evidence is limited and the effects are often short-term. And there's, I guess, the broader complex background that occurs for people, that there's the issues around challenges of obtaining abstinence, if that is the goal. There's often comorbid mental health conditions, there's social issues, potentially around unstable housing, there's stigma, there's a lot of different factors that can interplay in terms of the impact of treatment. And also, I guess, just the availability of treatment, particularly in regional and remote areas. So there are some movements happening here, but some way to go. And one thing I think we do know though is that punitive interventions, so those that imprison people or force abstinence, really aren't that successful. Where we do have more evidence is around broader harm reduction interventions that help to reduce the risk for methamphetamine and associated behaviours like risks associated with injecting or sexual risk behaviours. So we have quite strong evidence around the impact of things like providing sterile injecting equipment for those who need it, around safe consumption rooms, there's increasing evidence around the use of safer inhalation methods, interventions around bloodborne virus testing and treatment show that they have proved critical in reducing some of the associated risks with methamphetamine as well. So there's some positive signs here in terms of the types of interventions that do work. So as I mentioned, there's a whole raft of work going on, and I'd really encourage you to look at some of the work going on across some of the centres in Australia. These are just some of the recent papers just to show you how much effort there is occurring in terms of trying to advance treatment options. As Shane alluded to, some great resources, because I can speak highly of your book, Shane. It's a great resource. I've got it in my drawer next to me at the moment. And Shane's video series around drugs in the body. But also, yeah, head to the NDARC website. You can see our fact sheets. You can find out more about some of the trials that are going on. And I'd also recommend heading to the National Centre for Clinical Research on Emerging Drugs. This group are undertaking quite a number of trials and work to support the sector. So some great resources there. But if you'd like any more information, feel free to check us out on the NDARC website. And thank you so much.
Great. Thank you so much, Amy. That was really interesting. And thank you also, Shane. We've had so many comments and questions come through, which is really exciting to see. And I think we'll start off with you, Shane. You talked a lot around the damage to the cardiac system and the heart and the sort of cumulative interaction. For people who stop using methamphetamine, is it possible for the heart to recover? Does it take a long time? Do you know anything around that?
Basically, the damage you're doing is permanent. In extreme cases with cardiomyopathy, people may require a heart transplant. The risk is, so if you've got atheroma of the arteries, clogging of the arteries, it's not just going to go away. What you're going to do is stop damaging more. And what it means, however, is it's important for your GP to know you've been using, particularly if you've got any, and it's important for GPs to be, if they've got someone they know using, to check their hearts. In terms of the arteries, they may need stents put in. And I think one of the things we see is the deaths we see, if someone's done serious damage to their heart and they stop using a drug, they may still have a reduced life expectancy, and they may die 10 years after they've stopped using from heart failure, but the damage was done in that earlier period. Now, don't get me wrong, not everyone who uses the drug is going to get serious heart disease. That would be, alarmist. But if you regularly use this drug, and it's true of cocaine, you will be damaging the heart. And I'd strongly recommend anyone who is using the drug to be talking to their GP about cardiovascular investigations.
Yeah, that's a really important point. And I'm sure, a GP can always refer to a cardiologist if they want more information or more detailed look at what is actually happening with the heart as well. Continue on from talking around the effects. Amy, you mentioned that one of the things that we're seeing is that there's been contamination of methamphetamine with opioids such as fentanyl and other things. From both your and Shane's perspective, how does that kind of change the risk of toxicity or overdose? I think Shane is excited to take this one.
I'm very excited to take. Look, there's a couple of things. First, I just refer back to something Amy was talking about when I talked about alcohol, just before I talk about the opiate. The alcohol actually increases the effects of methamphetamine over and above using methamphetamine by itself. In terms of opioids, so fentanyl is highly potent, but it's true of any opioid. You've got a drug like a methamphetamine, which is increasing myocardial oxygen demand. The heart's needing to pump more blood and again needs more oxygen. And you're taking drugs that reduce oxygenation. You got CNS depressants, and that's a great recipe for an arrhythmia. So you got, I think Amy's point is people sometimes, I think, oh, look, they'll balance each other out. Well, they don't. They make everything worse. It's so Amy labelled, I mean, it's very hard not, if you don't know the drug's there, but I think Amy's point about naloxone doesn't do any harm and it's not going to get rid of the effects of the stimulant, but it would get rid of the effects of the drug. Now, there is a myth, by the way, that naloxone doesn't work on fentanyl. It's complete nonsense. You may need more doses. And of course, these days it can be put in a nasal preparation too. So you don't need to, people around you don't need to be experts in injecting in any way. So yeah, together, it's a recipe for higher harm.
Yeah, and I think I'd add to that, Shane, and say some of the risks that we're seeing as well is that it may be that people who are using stimulants who have never had exposure to opioids before, who are then taking what they think is methamphetamine or say cocaine, and it's adulterated with a very strong opioid. So it's really quite problematic. I'd really encourage people, this is an area of concern, I'd really encourage people, as Shane said, to think about naloxone, but also I mentioned the National Centre for Clinical Research on Emerging Drugs. They have been responsible for setting up a website called The Know, in collaboration with states and territories. I'd encourage everyone to check out The Know because it gives information about drug alerts that have been issued by states and territories. So you can find out about circulating batches of drugs that may carry a high risk. And also, I guess, as I said, drug checking where it is available within the state and territory. It's a great resource to get more information about what the drug contains and also get access to harm reduction information as well.
Great. And in terms of those harm reduction initiatives, I believe take-home naloxone is available at pharmacies. I know it can be a little bit of a difficult space, as not all pharmacies necessarily stock it, and it may not be easily accessible. But is it true that it is, available over the counter?
Yeah, that's right, Steph. So the Commonwealth Government, I mean, a number of states and territories had take-home naloxone programs, but the Commonwealth Government ran a pilot of a free take-home naloxone program for anyone to access it over the counter and across a number of states and territories, and then it got scaled up to a national program. So you can walk into any pharmacy and ask, hey, can I grab some take-home naloxone? They should hopefully give you a little bit of information about how to administer it. As Shane mentioned, it does come in an injectable and also a nasal spray formulation. But if you're someone who is at risk of experiencing opioid overdose or witnessing an overdose, you can get access to it. So it's a fantastic initiative of the Commonwealth Government doing that.
Yeah, the various forms are equally effective too. People shouldn't be worried about that. If you got access to the nasal spray, it's probably the quickest and easiest thing to do. But if you've got the pre-packed syringe, it's an intramuscular injection and it's highly effective.
So similar to like an EpiPen kind of setup.
Injection.
Yeah.
And when we're thinking about harm reduction initiatives generally, is there anything in particular that we could do or advocate for governments to kind of expand upon in this harm reduction space to better support people who use methamphetamine and reduce the kind of toxicity and overdose trends that we're seeing?
Yeah, I mean, I welcome everyone to throw their wish list in the sorry, maybe don't do that. The Q&A might get bombarded, but I think we can all add to the wish list there. I mean, Obviously, I think we're talking about harm reduction, but investment in treatment and exploring treatment options is really such a key thing at the moment when we're in a space where things are being tested, but we're still not quite there in terms of having the options and the access as well, particularly looking at those rates of harms in regional and remote areas. I know there has been efforts in that space, but it's still a key area. I mean, Australia is quite fortunate in our harm reduction space relative to some other countries in terms of access to needle and syringe programs. Obviously, we've got some access to supervised consumption facilities, and we're seeing internationally these facilities being set up around methamphetamine and stimulant use. So there's that consideration, drug checking helping. Yeah, there's a long wish list, and I'm sure people on this call would probably be able to, on this webinar, would be able to add to it. Shane, is there anything you would want to add in?
Well, I think treatment's important. One is we don't have any frontline pharmacotherapies that are the equivalent of, say, buprenorphine or methadone. But I'd also just put a shout out here to the residential rehabilitation sector, who do brilliant work and who have been the people who have had to take the strain during the methamphetamine epidemics, because it's been the only treatment option. What I think we're talking about is increasing the range of treatment options, whether that be trials of using drugs to reduce craving. I'm not sure, we've seen no equivalent of methadone, a substitute psychostimulant, and I have concerns that drugs that cause psychosis and heart disease, they may never be a substitute. We don't know, but we've been trying since the 1970s, and here we are.
And maybe
You
just
wouldn't
to
remember
build.
the 1970s, Steph, would you? As you said, yeah.
No, I was not born yet.
No, you told everybody.
And
All
I
right,
might just
sorry.
go on Shane's point as well, because you made some reference to mental health there. I guess it's not just treatment for methamphetamine, but acknowledging the complexity of what can be going on for people around who are seeking to reduce or to stop their methamphetamine use, and thinking about those wraparound services that don't just go, let's talk about your methamphetamine use, but bring together the necessary supports to help, I guess, maybe if it's needed, bring some stability around housing, around employment, or whatever else is needed as well. Yeah.
And recognising the signs and symptoms. Overdose heroin is easy. People come unconscious and stop breathing. This is a whole different type of territory. The people, those using those around, need to know what it looks like. In terms of medical interventions also, the emerging evidence on early and severe Parkinson's disease is something, again, that I think is worth noting, that people, doctors treating people with methamphetamine dependence should be aware as a possibility.
So Steph, when we said
Yeah.
there was a long wish list, sorry, we could probably keep going.
You weren't wrong.
Sorry.
I guess one thing that stands out to me is in thinking about some of the data that you presented today was kind of around that overlap with mental health and the sort of accidental injury or potentially self-harm or suicide, along with sort of supporting co-occurring conditions in treatment. Is there anything that communities might be able to do to better support people who are using methamphetamine who may have co-occurring conditions?
Well, it's a difficult one. Look, one of the problems in our sector that's been going back since Adam was first developing opioid dependence is comorbidities, and it's the need for case management. It's quite the problem is you've got people who you heavily dependent on a drug, and also have, in this case, the potential for a schizophreniform psychosis, major depression, suicidality. You need to manage both of those problems. And when we do talk a lot about comorbidity, by the way, and think about mental health, but comorbidity is also means other physical health. But I suppose, and how one does is a different thing, but severe psychopathology and severe substance dependence are related and both need to be treated.
Yeah, thank you so much. We've still got a couple of minutes, so I'm going to sneak in a couple more questions. But I want to take us back to the kind of effects of methamphetamine. Shane, one of the things that's kind of come up as a question is just around strokes, and you mentioned that strokes can happen in young people. So what
Yes.
is it that makes people more likely to have a stroke because of their methamphetamine use?
Well, methamphetamine, it's the high blood pressure, the spikes in blood pressure. Again, you're putting pressure on the vasculature in the brain, and that in itself can cause damage to that vasculature. Cocaine, for example, is known to cause ischemic stroke as well. It clogs the small arteries in the brain. But the primary picture, I did a study on this a few years ago, and I'm married to a neuropsychologist, so we talk about strokes an awful lot. The thing is, the primary effect is you've got what's called an aneurysm, but think of it as a bubble in the wall of an artery, and that's a weakness. And you're pumping a drug through that's suddenly there's a huge spike in the blood pressure going through that vessel, and there's a bleed. So, and that, as I said, the thing about those bleeds, they tend to be deeper in the brain than general strokes. And that means that I said 30%. When I did the study of strokes with methamphetamine, in all of those cases, it was, and they were fatal strokes. It was the first stroke they ever had. Now, the thing is, we don't know whether we've got an aneurysm, or most of us probably don't. But it's certainly something to keep in mind. But it's to do with blood pressure.
Great. So it's quite different to some of the other effects, which are cumulative over time and depend on how much you're using and how often.
Yeah, well, it does damage the vasculature in and of itself as well. But I had to say the most common presentation we had was a burst aneurysm. But there are also innate weaknesses in where various vessels join each other, the carotid arteries, where various circles of Willis, circle of Willis, where whenever there's two vessels joining together, there's a weakness. But the point is also that these drugs actually do damage the vasculature throughout the body. Yeah.
Great. Thanks so much for explaining that through to us. We've probably got time for maybe one more question. And Amy, I think this is probably a good one for you. It kind of touches on, and it's not just specific to methamphetamine, it kind of is around the way we talk about all drugs. We've had two people ask about why we've been using the terms dependence instead of addiction. And I just wondered if you could kind of talk to that perhaps.
Yeah, most definitely. So in terms of the language that we use, as we know, language is so important when communicating about substance use, but mental health and so on more broadly. When we're talking about dependence, often we're talking about it because it's a clinically significant and recognised condition. So we use different diagnostic manuals, I guess you would say. There's a few different classification systems, and they have criteria around when people would meet a clinically significant threshold. So we often talk about substance dependence or substance use disorders, kind of aligning with the terminology that's being used. There has been a little bit of a pushback around the terminology of addiction at times too, as well, in terms of potential associated stigma. So the main driver is because of that diagnostic terminology we use. But yeah, it's also about talking to people and understanding their preferences around language too. I don't know, Shane, if you want to add anything around that as well.
No, I mean, I suppose at a level we're into semantics here, but I think I tend to use the term dependence, but in the DSM it'd be methamphetamine use disorder. But I think the major point is just what Amy said. Labeling people as addicts is not helpful. Saying someone is dependent on a drug, I think, gives it a completely different slant in terms of I think it's less stigmatizing.
Yeah. And Steph, I know we've got to wrap, but if anyone's interested, there's some fantastic resources online. There's the Language Matters Guide, which really talks about and has been researched in terms of talking with people who use drugs around what language they feel comfortable with. So really, if people get a chance, encourage having a look at some of those resources.
Yeah, great. Amazing. Thank you both so much for sharing your time and all your expertise. It's been wonderful today, even though it's quite a serious topic, and for anyone who it may have raised concerns for, please do feel free to reach out to Lifeline or 13 Yard. But we really appreciate all the information that you've shared with us. So I'll just wrap up today. So we will be holding more Cracks in the Ice webinars and putting new resources on Cracks in the Ice. So I would encourage you to subscribe to the mailing list if you're interested in receiving further updates. There will also be a recording of today's webinar, which will be made available via the Cracks in the Ice website. So thank you, everyone. Particularly thank you, Shane and Amy, for joining us. And we all hope you have a lovely rest of the day. Thanks so much, everyone.
Thank you very much.
Thank you all.